Hi, I'm Dr. Sunny Hatch. I'm a faculty scholar in the John P. McGovern Academy of Oslerian Medicine, and today I have the distinct honor of speaking with Dr. Gwyn Richardson, a gynecologist-oncologist, faculty in the Physicians Healers track at the School of Medicine at UTMB, but most notably the recipient of the John P. McGovern Academy of Oslerian Medicine Excellence in Teaching Award. And I felt her to be the perfect person to have the discussion regarding the complicated concept of hope. So, Dr. Richardson, let's start off with, what do you think is the definition of hope?
Hope has a couple of different meanings to me. One is a wish for something better. It typically counts towards the future, a change from where someone is now. And the other is, instead of it kind of being this hope or wish that it will be better, it's a belief that it will be better. So it's nuanced both ways.
You know, to me, I don't think I've ever successfully defined the word without using the word in the sentence. There's almost a continuum of hopeless to hopeful. And to me, hope kind of moves on that continuum. Maybe hope, even though it's a four-letter word, maybe it's too big for a definition. But how you define it is great, that desire. And that's a very positive way of thinking of hope. You know, I became hope aware, if you will, at the end of the 90s when I had a patient that came to see me. And she was alone in this world. She didn't have any living relatives except for her toddler son, which came with her to our meeting that day. And he was adorable. He was just had a wonderful personality and these little rosy red cheeks. Unfortunately, she, when she was breastfeeding him, she developed bloody discharge from the nipple. And ultimately, she was diagnosed with breast cancer, actually very advanced breast cancer. She was there to see me, to talk about radiation therapy. You see, she'd already had the breast removed, so she'd had a mastectomy and had chemotherapy and was ready to start the next realm of treatment, a round of treatment. When I got ready to examine her, unfortunately, when I felt the chest, I felt nodules underneath the skin. And it felt like cobblestoning. It's almost like I can feel it now underneath my fingers. There was a wonderful physician that I worked with. His name was Dr. Roberto Logroño. And he was head of cytopath. And I called him down. He was always ready to help us out with our patients. And he came down with his team and his little rolling cart, and on there were all of his instruments and his microscopes. And I shared with him the story that the woman had of being a single mom and what she had gone through. And what we needed to do was to biopsy one of those nodules on her chest. And he walked in there. He was always so kind and so respectful, and obtained the tissue. And we looked under the microscope. Now, we knew what we were going to find when we looked. And so we didn't talk. I just walked back into the room and took the woman's hand. And of course, Dr. Logroño knew how difficult it would be, not only for her, but also for me. So he came in right behind me, and he put his hand on mine. And we stood there, and she started talking about hope. And of course, she was weeping at the same time. The first thing that she said was, I hoped it wasn't cancer. I hope it wasn't true. And then the second thing was more so, I hope there's something you can do for me. And then the third, of course, was about her son. I hope I can find someone to take him. And the fourth I said, I hope I don't die in pain. It was at that point that the child started to cry, and she picked him up and she cradled him next to her chest. And we slipped from the room, and we had never said a word. Again, he took my hand and he said, Sandy, which is what he'd call me, we cannot take away her hope. Mm-hmm. Now, that patient gave me the gift, a gift of recognizing the power of hope. But you know, Dr. William Osler has said the same thing. In his writings, he says, it is a hard matter and really not necessary to tell a patient he's beyond all hope. Now, in this case, hope perhaps was a response to a form of suffering. Mm-hmm. Do you think that hope is always a response to suffering?
I certainly think it can be. Many times we can afford some healing, even when we cannot find a cure. And in situations like her, or situations with some of my patients, that's my opportunity. Mm. May I allow some healing to happen for my young patients with cervical cancer who have disease I know, looking at my pictures, I can't make go away. I'll take an example. Neuroendocrine cancers of the cervix are incredibly rare. They act like neuroendocrine cancers of the lung, small cell cancers of the lung. And if we find them really early, so very small volume disease that doesn't have metastasis to lymph nodes, we may be able to cure those patients. May. Even with surgery, chemotherapy, radiation, we may not. Unfortunately, what we frequently see is that by the time someone presents, and they may have had normal pap smears in the last year to 2 years, but by the time they present, there's frequently metastatic disease. And then we begin a journey of trying what we know has the potential to extend life, but may not ever provide a cure.
There's a coexistence, it seems, of despair and hope in some cases. Do you think one negates the other?
They're almost yin and yang. They're two sides of the same coin. And in some senses, despair occurs when you feel that you've lost all hope. I've seen patients where they say, literally the statement is, I have no hope. And instead of that being the final answer, part of my conversation says, I may not be able to treat you with chemotherapy or with radiation to make this go away, but it doesn't mean that I can't treat you.
You know, you talked about our patients, and they often connect hope with their faith. The King James Version of the Bible, in both the Old and the New Testament, it has many passages relating to hope. But the one that patients tend to frequently visit is in Psalms. And it's Psalms 94, where it says, I cried out, I am slipping, but your unfailing love, O Lord, supported me. When doubts filled my mind, your comfort gave me renewed hope and cheer. Perhaps that's a Christian point of view, but how about the other cultures, or people that are atheist and agnostic? Do they have hope?
I've found they do. Many patients who, let's say, are agnostic, some of their faith in what the world is becomes a statement of, are there things in my life that I'm happy I have done? Have I made a difference in this world?
Mm-hmm.
And whether it's through what they, what their occupation was, I will speak to two wonderful ladies who have both passed. They were partners. They were both attorneys. And they helped many families that were lesbian and gay be able to adopt children.
Mm-hmm.
Both of them horrifically had ovarian cancer. One had a high-grade ovarian cancer. The other had a low-grade ovarian cancer that recurred years later. And I had the privilege of caring for both of them. And their hope was that they had left the world a better place. And by being who they were, mm-hmm. they had made tremendous sacrifices, but tremendous benefits had been given to families across the state of Texas. And literally, when they started their practice, no one who was gay or lesbian was allowed to adopt a child, or when people were getting divorced, mm-hmm. their children were being taken away and given to the other parent. And so both of them, as they were getting near the end, looking back on their lives together, and then the second person who passed away about 5 years after my first patient, both of them, their life was, we have left the world a better place.
They seem phenomenal.
They absolutely were, yes. Absolutely.
I too have had people that profess to be atheists to speak of hope, and as well as agnostic. If we think of cultures, I'm not sure I know how to be culturally correct when it comes to hope. I try to learn more. How have you approached that or taught it with your students?
I will tell you, during COVID times, it's a little more complicated, mm-hmm. as we limit our family members being with us. But a lot of it actually becomes a discussion with both the patient and then their family members, mm-hmm. of what is important to you. And really, it comes down to each individual person, to what gives them, I find the word joy, what has brought them joy. Then those small things to get to that point again are really what I look at.
What do you do when the family has a different hope or expectation than the patient?
That's complicated.
Yes, it is.
And in part of my discussion has been when I've had some, for example, I have a patient who's older. She's been diagnosed with a cancer. She understands that to be treated for this, she will need to go through a fairly intensive treatment, whether it's chemotherapy or radiation. And her family is all for it. And she'll kind of smile and look at them and then look at me and say, I'm not doing that. And I hear a, but Mom. And then they'll turn to me and say, we'll talk about this again. And my response, first of all, is to understand where she's coming from, or try to understand where she's coming from. If there's a real, hesitancy with receiving chemotherapy, is it that she watched one of her parents or a family member who received chemotherapy for a different type of cancer, and she really saw them suffer. Is that what makes her nervous about it? Or is it that she has the thought of, I've lived a good life, I've done what I've wanted to do, and I'm okay to go to the other side. And I don't want to be in doctor's offices for the last period of my life. I want to spend my time with my family. I want to travel. Because our treatments necessarily have side effects, most of them at least.
You're right.
And so with the family, that's part of the discussion that I want them to be able to hear. If it's their mom or their sister, do you understand why she says, I don't want to do this?
So what you've discussed is you create an environment in which an open discussion can occur regarding hope. And each family member or whoever is coming with the patient can discuss it openly at that time. Whereas once they get home, it may be a guarded situation and not even occur. You're put in a position because of what you do of breaking bad news, unfortunately. So William Osler, or Dr. Osler, writes, what is your duty in the matter of telling a patient that he is probably the subject of an incurable disease? One thing is certain, it is not for you to don the black cap and, assuming the judicial function, take away hope from any patient. So, how do you tell a person, such as what you've described, that they are in fact terminal without taking that hope away?
Let me start with the neuroendocrine patients, because that's to some extent a little bit easier. Not easier in the sense of their treatment, but there's more data that says this is the reality of what we're working with. And I have a couple of ladies right now with this disease, unfortunately. So I start off the conversation with, this is a very aggressive cancer. We will certainly do what we can with our best available data to help you. But I have to be honest, there's a lot of ladies that we are not able to cure from this disease. Then I let them start to ask more questions. At the very beginning, when I first meet patients, some people are not ready to hear their prognosis. Their family member might want to know, but they're not ready. And so I will always ask, if it's the family member who's asking, do you want to hear this? And if the patient tells me, I don't care what you tell me for percentages, I want to try treatment and see how I do, then I will always tell the family member, if she says it's okay, I will step out and answer this for you. But she doesn't need to hear this yet. She wants to try therapy.
That's
and
really
it's
good
very
advice.
reasonable for her to try therapy. And that's one of the ways I always try to make sure that they're ready to hear that.
Which gets us into gaining the confidence of a patient. And Dr. Osler actually writes about that as well. So William Osler writes, once gain the confidence of the patient and inspire him with hope, and the battle is half won. So should we make every attempt to give hope when hope isn't present?
I think to the best of our ability, it's how you define hope. I'll step back to, even if I can't cure you, I can try to buy you time. I can't promise that. And I'll say that from the beginning. I will smile and say, We have some of our patients who have certainly defied our expectations. There is a statement, someone is the 5%. I don't know who it's going to be. And based on how people tolerate therapy and how they're doing, we'll figure it out.
Ironically, research has taught us that the placebo often works, right?
Mm-hmm.
So there is a placebo effect, I think, to a patient's determination to live and their will to live. And I have patients that walk into my clinic, and I'm sure yours as well. You think, how is this person alive? Much less walking in and have full quality of life.
Right.
And so do you think that hope is a placebo? Can we maximize its placebo effect?
Oh, I think we can. I will agree with you. I have patients, when I look at their CT scan, I don't know how they're standing in front of me doing everything they're doing. They may be having a full-time job, they're taking care of children, they're going 90 to nothing. And they're like, I'm just going to keep going. I'm doing fine. Like, are you sure you're fine? Yes, I'm fine. You check with their family and they're like, they're doing great. Okay. Always double check with the family. Sometimes they give you their best foot forward.
It's always a nice surprise to see them coming in.
Exactly. I'll also say, when we talk about hope, if we have patients who truly believe that they won't get better, it's the opposite.
Exactly.
Patients who I have a 95% chance of curing, and they stand there, and every time I see them, I'm going to die from this. I've seen that happen. And I'm like, statistically, you should not recur. You should be cured. You should do very well. And they don't.
I've learned to listen to that patient.
Exactly.
I don't know if an intervention of changing the pathway of hope, moving them in that continuum that we spoke about, from hopelessness to hopeful, if that makes a difference. I've certainly tried to alter that continuum. But you're right, and they're the ones that tend to suffer the side effects as well. So William Osler says, a disease may be incurable, and the best we can do is to relieve symptoms and to make the patient comfortable. It is a hard matter and really not often necessary, since nature usually does it quietly and in good time, to tell a person that he is past all hope. In other words, we don't have to tell a person. We don't have to take it away, I guess. And he quotes Thomas Brown as saying, it is the hardest stone you can throw at a man to tell him that he is at the end of his tether, and yet, put in the right way, to an intelligent man, it is not always cruel. So that's really what we're talking about today, is that fine line of how you can have an honest and open discussion with someone and evolve that hope, much like what that patient did for me. She evolved hope in that conversation, going from, I hope it wasn't cancer, to, I hope there was something you could do for me. I hope there's someone here to love my son, and I hope I don't die in pain. And I watched that evolve. But there's also a competing element, I think, to hope, and that's denial, where it's often difficult to move a patient in a productive pathway or one that's more hopeful because of denial. What has been your experience along denial?
Some of it definitely is dependent on each patient, and each experience is different for each patient. I smile and say the best foot forward is always at my office.
I like that.
Which is
seal
why,
it.
yes. Which is why I always am very happy when family members particularly when patients have been on chemotherapy for a long time. I'll take my metastatic ovarian cancer patients, for example. As you know, most ladies with ovarian cancer will recur at some point. And once they recur, they will spend their life on and off treatment. Eventually, most women with ovarian cancer pass from a bowel obstruction. It's a functional obstruction. It's not within the lumen of the bowel, but it's just that there's peritoneal seeding that lands upon the bowel, and truly it winds up as a functional obstruction. There's not surgery you can do for it, because by that point, patients have had multiple rounds of chemotherapy to which they've become resistant. So doing surgery to remove the cancer leaves you with no effective treatment immediately after surgery. And so as patients kind of walk that path of moving from chemotherapy to chemotherapy to chemotherapy, with gradual increases in nodules in their abdomen, many times they'll feel pretty well for a long time of, well, I feel fine. There's not, I know you say there's disease on imaging, there's my CA-125 is elevated, but I don't feel anything. At some point, symptoms start to arise, and perhaps, as Dr. Osler said, the human body starts to address itself. And I rarely have to tell a patient, we're at a point I can't give you chemotherapy anymore. And in part, that's because they really don't feel well enough to come in, as I say, to put their best foot forward and to come into clinic and to get chemotherapy. They just really don't feel good. A malignant bowel obstruction, we manage frequently. Patients will wind up coming in the hospital, getting an NG tube. If it's a partial obstruction, sometimes we can kind of nurse it along and make dietary changes and say, don't eat corn and don't eat beef, and you'll be okay for a while. At some point, when it's more advanced, we will frequently put in like a venting gastrostomy. So a tube that allows people to eat and drink, but instead of throwing up, they now can kind of turn a little tube and it lets them drain their stomach. It allows them to be comfortable, maintain dignity, allows them to continue to eat, but we don't really do treatment at that point. And they understand, because of their symptoms, why. It's answered in its own way.
Is there such a thing as reasonable hope?
Yeah. I smile and say someone has to be the 5%. Someone's going to be my ovarian cancer patients with recurrent disease. Someone's going to be in that 20%, the 1 out of 5, who we will give them second, third, fourth line therapy. We'll see a complete response. We'll see another section that has stable disease. As long as they've got stable disease, we're going to keep going.
So it's sensible and moderate, basically. Should hope be nurtured?
Absolutely.
That was an easy answer.
Mm-hmm.
There was a French philosopher named Marcel who wrote about hope actually during the oppression of the Nazi occupation of France. And within that writing, he emphasized that it's helpful to discuss the phenomenon of hoping rather than the concept of hope. That hoping affects the whole person, separates wishing and desires. He goes on to write that hoping has the nature of humility, of responsiveness, of waiting, really awaiting. Not so with hope, which is rooted in catastrophe. You've talked about it today many times, about recognizing ways that hope impacts not only the life of our patient, but also that of their family and caregivers. You've talked about fostering hope in a patient that's actively dying. So, is it then a myth that physicians can take hope away?
I'd love to say it was a myth.
Yeah.
I certainly think we can. We have the capacity to potentially do harm in our way that we approach disease. I'll take an example, and some of it is what, it may not be what was said, but it's what was heard. I received a phone call from, I have a new patient, newly diagnosed cervical cancer. She does not live close. And I am in the process of arranging for her to get her treatment close to home because she will necessarily receive chemotherapy and radiation. And she cannot drive back and forth from here to, from Galveston to her home. And she had gone to the ER yesterday morning because she was her pain had worsened. She has not yet started radiation therapy. She was actually scheduled to see the radiation oncologist next week. And her husband called our clinic, panicked, because what he heard from the ER physician was the cancer spreading everywhere and it's coming through her skin. A little while later, we got a phone call from the transfer center to transfer her here because there's not a GYN oncologist where she lives. And in the interim, I had been able to speak to the radiation oncologist who was scheduled to see her next week. Radiation oncologist agreed to see her this morning. And we had imaging from UTMB that was within the week. And she has an advanced cervical cancer. It's not growing through her skin, but it is a necrotic mass sitting at the base of the pelvis. It's invading into her bladder, most likely, but appears to be confined to the pelvis on our best imaging so far. And her husband, who I had met the week before, along with her, when we had our conversation was, based on everything I'm seeing, you are a candidate for chemotherapy and radiation. This looks like it's confined to the pelvis. You'll have a PET scan. And we will work with you, and the radiation oncologist I'm working with is excellent. They will work with you to treat your disease. Mm-hmm. What he heard from the ER doctor was the cancer spreading everywhere and she's going to die soon. And so we reached out to the ER physician when he called me. He tells me, it's a necrotic tumor, it's a pelvis, blah, blah. I said, that's what we've seen and we know that. She's seeing the radiation oncologist tomorrow. Mm-hmm. He said, oh, great, okay. And I'm like, be careful how you phrase things. And then we spoke with the husband and said, they haven't seen anything that we didn't see. I spoke with the doctor. It is not coming through our skin, at least based on the reports that he gave me. He would have told me if it was coming through her skin, but he said it's all in the pelvis and it's a large tumor. So that care of how you phrase what you're seeing, which, yes, it's a large tumor, but it's still treatable, is incredibly important in how we frame things. And we can frame it realistically. Mm-hmm. That patient wanted to know what the chances were that we could cure her. We had that conversation. I have other patients that are like, just treat me, and we'll go from there.
So Dr. Osler and Dr. Logroño were right. Mm-hmm. We as physicians cannot take hope away. To do so, you strip away our foundation. It has been present since creation and will be there to our end. I propose to you that hope is the glue that binds humanity and transcends race, sex, religious belief, and economic status. So Dr. Osler was relevant yesterday, today, and hopefully tomorrow. Thank you for listening to this segment. And as always, remember to practice medicine with your head, your heart, and your hands.
UTMB Health, working together to work wonders.